what a Z-score system has been used has been mentioned in the echo report, so that if this goes to some other unit, they can also compare this patient. That we have understood now. So accurate weight and height, use the same Z-score system is important. And when to do echo, nowadays frequency has been increased by recent guidelines. You do more echo. Earlier we were also doing more echos. I think we were always doing aggressive in echo, but now guidelines have to come into picture that you say you do more echos. Still, if the child is in the hospital and not improving, you are doing every day also. But if the child is improving, maybe in 3 days, 4 days, you can do the echo. But yeah, just the clinical features will decide when to repeat the echo. If child is not responding, maybe in daily, you are doing 3 to 4 days daily echo. The child is 3 days old child, you may not repeat on 4th day, you will repeat on 5th or 6th day. So that will matter, because in first 5 days, I have rarely seen a coronary artery involvement or dysfunction. But yes, we have subtle signs which start suspecting, like perivascular brightness, something unusual about the heart. That is true. And one more point I would like to add here is, if you are sending a patient for echo in first 5 days, it has to be sedated echo. Child is irritable, edematous, fever, you will not get a good window. Forget about the Z-score. So you ensure that it's job of the echocardiographer that the child has to be fed well, fever-free at that stage, given sedation to do the basic echo assessment. Otherwise, in a crying child, coronary arteries will not be accurate measurements, and you will mess up with the reports.
So in continuation only, you can take this question also, sure. Sir. Like, again, that child is clinically improving, but serial echocardiography shows increasing coronary artery G-scores. And again, to highlight and reiterate that use the same calculation scores, because if you use different G-scores, then there may be a calculation difference. And like now, several people have seen that if you use there are several, at least 5 to 7 G-scores systems are available, and if you use a G-score A in comparison to B, there will be almost change of more than 1 plus G-score. So don't use like different G-scores in a patient. So how should coronary artery aneurysms be classified when you are having aneurysms, and why should the same Z-scores, again, if you can reiterate that is important.
That we discussed, the Z-score equation has to be same method, as we understand, same system has to be followed, so that if this goes to some other unit, at least child is being taken care well. This has been defined recently now, and the dilatation only is 2 to 2.5. Now here I would say, I have reservation about this criteria. Lot of fewer patients without Kawasaki would have this 2.2, 2.3. So this is very non-specific, but let's go with the clinical system here. Let other labs, that less than 2.5 is Kawasaki. I'm still not able to digest this part, but anyway we are doing it because mostly there are clinical criteria along with it. And then small aneurysms 2.5 to 5, medium 5 to 10, and large more than 10, or absolute dimension of more than 8 mm. Now we had a discussion in our unit also, why absolute dimension of more than 8 mm? Why not 7, why not 10? So they found that this has more chance of rupture. More than 8 mm is absolute value, irrespective of the age, that they can rupture or they can thrombose. That's why their absolute value comes into picture when you're talking about more than 8 mm. So Z-scores are reliable and should be done in all the cases. Of course, you maintain the discipline. As I say, be meticulous about the dimensions. And sometimes, LAD's proximal and distal part also should be seen. Sometimes distal is more dilated and proximal is less dilated. So make sure, in our team, we make sure that RC origin, RC mid, RC distal are defined. Similarly, LAD proximal, LAD distal are also defined. So that if it's seen very well, that means you can measure it. That means possibly this is dilating. So maybe next 48 hours give you better values. So try to have more measurements and more sedation in these cases of measurements.
So Dr. Neeraj has highlighted three important things. One is that whenever you are doing an echo in child, sedative echo is required. And that is a very important, because in seeing a coronary artery, and even in a smaller child, in a struggling child, is a very difficult thing. So the involvement of pediatric resident is essential whenever you are doing echocardiography. It should not be just do echocardiography. Second thing is height and weight. That should be very accurate. Even if 1 or 2 centimeters change in height can change your G-scores. Weight, 1 kg or 2 kg difference can change your G-scores. So that again a problem. So take accurate height and weight, and that is also a very difficult thing doing in a struggling sick child. Taking accurate height and accurate length in a less than 2 years is a very important thing. And third thing which has been highlighted is that 2 to 2.5 G scores, which can seen in a febrile child. But the context is most important. If you are suspecting a Kawasaki disease and your diagnosis clinically, you are diagnosing a Kawasaki disease, in that context, 2 to 2.5 G scores can be taken as a coronary artery abnormalities. And the good part about these coronary artery abnormalities are these are transient. And fourth thing which has highlighted is that absolute diameter of the about the giant aneurysms, and Japanese has still not very having an acceptance about these G scores, and they say that if their G scores the diameter based coronary artery assessment is still holds true. That is because if you are having a coronary artery diameter which is beyond 8 mm, and more recently it has been defined as a more than 6 mm also, has a very high risk features of development of coronary artery ruptures, and also a long term sequelae to develop a coronary artery disease in these patients. So those things are very important when you are dealing with a Kawasaki disease
So
patients.
one more thing for the pediatric residents, when the patient is coming for echo, it should not be after sampling. If patient coming after sampling, he will not allow the echo. So echo will not be done on that day. Echo will be done next day then. So first echo and then sampling.
So again, that some like echo is a standard of care, and echo is the imaging of the choice in Kawasaki disease of the patients. And so, but sometimes you may not be able to see all the things which you want to see. So again, an 8-month-old child with KD had a proximal LAD and RC aneurysm on echo. Distal segments and LCX are poorly visualized because of several reasons, and sometimes you have a severe tachycardia and limited windows also. And repeat echo is suggesting some progression, but anatomy is still not clear. So is there any role of CT coronary angiography in these patients, and what does CTC add and information beyond echocardiography? And there is some update in the AHA 2024 statements about the role of CT coronary angiography in these patients.
So if you were there last time, a lot of Manful Singh has come last time, and we had a lot of discussion about CT scan. And I accept that we don't do CT routinely in our unit, but now we have moved on gradually. So CT, because we understand distal part is not seen. But mind you, proximal part in an infant is very well seen.
Yeah.
Proximal mid part of circ, LD and RC are very well seen. So most of the patients would have proximal involvement, not distal involvement. This has to be understood and accepted. Now few patients will have isolated distal involvement only. Their CT may be helpful. So only those substrates, we are thinking that this is strongly Kawasaki, resistant to IVIG, and I'm not sure what is happening with the child. In my unit, I would say no CT has been done here. Possibly we are missing the distal aneurysm alone. But if you have a proximal aneurysm, I don't see a point to do CT scan today. Today means in the active phase. If it's a very giant aneurysm, even then, I'm not interested in looking at distal part today. For the long term, after 6 months, 1 year, I see a point that maybe distal I need to see to decide to about anticoagulant or to decide therapy. But in current state, in acute stages, the guidelines for CT will remain limited, and they will remain only when you say my patient is Kawasaki, echo is normal, and patient not responding to my standard therapy. Then I would like to see whether I have a distal aneurysm. And distal aneurysm, it can be septic aneurysm also. It's not only Kawasaki. It can be a staph aneurysms. You can have some other cause of coronary involvement in distal part also. So that may be helpful in acute stages. So what CTC adds, of course, this will evaluate distal part. But do we need to see distal part is to be decided. And that has to be a clinical judgment. But yes, for a long-term follow-up, CTs will be done, and it will be more and more used in future.
Thank you, sir, for highlighting this issue, and he has highlighted beautifully the dilemma of the evolving literature about the CT coronary angiography in these patients. And the recent 2024 has suggested that if you are having a giant aneurysms, there is some role of CT coronary angiography in delineating the coronary artery abnormalities. Maybe you are dealing with a complex aneurysms. There may be a distal aneurysm which is having a thrombus. So those things can be picked. But again, this is not uniform, and again, the literature would support, but the definitive role in the long-term follow-up is there about the CT cornea angiography in these patients.
So in acute stage, if they have giant aneurysm, suppose I have a proximal LAD giant aneurysm, my therapy remains same. Whether it's a distal aneurysm also involved will not change my management unless there is thrombus, but even then I am anyway giving anticoagulant. So in the giant aneurysm, if I have a proximal giant aneurysm, I am doing the same management. So that's why I said